Hello, everyone, and welcome to our week where we are talking about working within the managed care system as well as consultation and referrals. So, we'll be touching on each of these areas, and there are lots of supplemental materials that are in the module, so please be sure to visit those. So there are many different types of managed care plans, and here you will see the various types listed. As discussed in the book, some, like the PPO, have greater flexibility and freedom when it comes to clients choosing their providers, and others are going to be more limited in that freedom to choose providers, like with the HMO. I know that your book really details the differences between each of these, but I want to briefly address the EAP, or the Employee Assistance Program. These can be incredibly valuable programs for businesses to offer to their employees and their employees' families. When working in an agency or a private practice, you may have a contract with a local business that will allow you to serve as their provider for their employees who want or need to access their employee assistance program. In this arrangement, typically the employee does not pay you, but you are paid by their business with who you have the contract. This can sometimes bring into the picture some questionable gray areas surrounding ethics, and I want to address an example of this. For example, if a client voluntarily chooses to access counseling from you, or if a client is referred to you by the administration in their business in order to address the employee's aggression in the workplace, well, then the payer, which is in this case the company or the business, is also your client. So they might have access to client information. I'll give you an example of my past work. So in my old agency, they contracted with the local casino to be their provider for their employee assistance program. And when employees were referred to our agency for mandatory anger management because maybe they had an outburst at work, maybe they were not following procedures and kind of bucking back against the management, we had to report back to the casino regarding their progress and their fitness to return to work. So a lot of times these employees were suspended from work and they were getting counseling through the EAP so that we could give an update to the employer to say that they were fit to return. So in these cases, you need to really be very clear on the parameters of your EAP contract, and you have to be informed on any limits to confidentiality. This will also need to be thoroughly reviewed with your client so that they can consent to treatment with the full knowledge of what can be shared with their employer, so the full knowledge of limits to confidentiality beyond the general limits that we always talk about with all clients. As you read in the book, this also applies to the other types of managed care organizations. So be sure you're familiar with protocol and do not offer a guarantee of confidentiality where it cannot actually be followed through. I wanted to offer some considerations when working with managed care organizations, and this is really detailed and outlined in the book, but I wanted to kind of specify a few here. So we want to understand, before joining with a managed care organization, we want to understand what models of therapy and counseling they promote. For example, are they very much about very brief forms of therapy, offering 5 to 6 sessions, or are they going to allow you to offer maybe more insight-oriented, kind of digging down theoretical approaches to their clients, which will take many more sessions than that, more long-term therapy. So we want to ask, is there a limit to the number of covered sessions before we agree to serve a client who is covered by this managed care organization? There are lifetime caps on services that can be provided with certain companies, and then there can also be yearly caps on the number of sessions. So we need to understand this so that the client and we are on the same page before we enter into a therapeutic relationship. Additionally, we need to recognize what the diagnostic restrictions are for the reimbursement for care. So for example, will this MCO reimburse for adjustment disorders? Do they have a policy where they don't reimburse for adjustment disorders? A lot of companies will not reimburse for V codes. They will want an actual diagnosis. And so this is something you need to be aware of before you begin working with them, because if you are working with a client and they cannot, if they don't meet the criteria, very legitimately, if they do not meet the criteria for a certain diagnosis that is required for reimbursement, you are not able to diagnose them with that under our ethical code. So you need to be sure that you are ethically diagnosing and that clients are aware that they may not be reimbursed if they do not meet criteria for certain diagnoses. This might require some out-of-pocket pay, and you can negotiate that pricing with them, but they do need to be aware of some of the limitations that are entailed when you are working through an MCO. So thinking again about the limit to the number of covered sessions, we need to ask ourselves, am I confident that I am knowledgeable enough and prepared to work within that time frame? And I mentioned before the difference between some brief therapies versus longer term work, more insight-oriented therapies. We need to understand where our strengths and where our specializations lie. Maybe we want to engage in some professional development or extra training so that we can really become fluent in that solution-focused brief therapy if that's what's required by the MCOs that we are providers under, because we really need to be able to offer clients realistic expectations of how long services will take for them to experience healing, for them to experience some shift in their current level of wellness. This is important because some clients do not have the financial ability to continue paying for services beyond what is covered by their insurance company. So we cannot ethically run through their 6 covered sessions and then they're still, raw and open and digging through lineages of trauma. We can't just stop providing them services. So we do have an obligation to serve clients through modalities that are going to be effective and also so effective in the healing, but also effective in meeting the requirements of the MCO. Sometimes if we run out of sessions with a client, we can ask for more sessions from the MCO, but we will need to share client infos, possibly session notes, and a new treatment plan. And these additional sessions are not guaranteed, so clients need to also be aware of this as they're working with you. I think this also applies to if they're doing work with you in, let's say, one area for anger management. We'll use that example again. And then they start to process some past trauma. You might need to have some parameters on your counseling session and use some psychoeducation to let them know if you want to process this trauma, it is going to take more than the allotted sessions, and it's going to likely intensify some of your emotional distress before it gets better. So are you prepared and financially able to do that? And it is our duty to advocate for our clients. If we're working for clients that need extra sessions and it's getting denied, that request is getting denied by the MCO, we need to go ahead and initiate a challenging process of that. It's our duty to advocate for our clients. A lot of our clients do not understand how these systems work. So part of our work in our training, and then more so even in our professional work when we start to actually work with MCOs, we need to start to understand the inner workings so that we can help our clients navigate this and advocate for and with our clients in doing so. So if you're wanting to become a provider with managed care organizations, there are quite a few steps that you need to follow. One is accessing licensure, so going ahead and getting licensed. Some MCOs require full licensure at your LPC. Others will allow you to come on board and get paneled with them if you have your LPCA, so it just varies. However, sometimes they have practice requirements that are set. So if you have not practiced for X number of years, they will not take you on as a provider. Additionally, you cannot have any open actions against you. You might get rejected if there are resolved actions that were open but are now closed, but you will definitely get rejected if there are open actions. If you do have resolved actions and it shows that you were not at fault, you're more likely to become a provider. Additionally, you need to access liability insurance. All of you should likely have that right now. That's something that we ask you to get as soon as you enter the program. You want to go ahead and maintain this liability insurance from now throughout the scope of your practice. You might want to keep the liability insurance that you have, or you might want to shop around for other companies. But typically, you're going to want at least a coverage of $1 million per individual claim, and I like to say $3 million per aggregate. So look for plans that cover you to that degree. You'll also want to go ahead and apply for your National Provider Identifier. If you follow the link here, it will take you to a web page that directs you through the process of doing that. This should take about 20 minutes, but there are some pieces of it that we are maybe not as familiar with. And so in terms of languaging, when you're asked to select a taxonomy, be sure to select behavioral health and social service provider. If there's something else that fits you as you get out of this program and start to specialize in different ways, you can select that. But typically folks choose that behavioral health and social service provider option. You'll also want to have a really solid CV in place, your curriculum vitae, so you can begin building this now. And I would recommend revisiting it and updating it every quarter or every semester. You will include in this your education, your credentials, like your licensures, any certifications, and then also training, clinical experiences, things related to your ability to effectively provide mental health care and services. A really solid CV can go a long way, not only for becoming paneled with insurances, but for being on the job search. So you'll be asked to do this in your internship class. However, if you want to go ahead and start building it now, it could never hurt. You'll also want to get your employer identification number, and then you will apply individually to each MCO under which you want to be a provider. You will specify your clinical expertise and the populations that you work with, but you also need to recognize that at certain times, certain MCOs will reject you if they have enough providers in your geographic location that are already working through your specialty. Sometimes this goes in waves. So for example, you could maybe apply in March of this year and it's closed to people who are working with people with substance use disorders. Maybe they have enough providers in your area, but then in 6 months, maybe it's reopened because there's been some balancing out of that supply and demand. You will also need to re-credential every year. So there will be an annual review and you'll need to go ahead and do that process on time, or you will be dropped as a provider for your MCOs that you are already listed with, meaning that your clients who are coming to you and who are billing that particular insurance will not be able to be covered. So make sure that you're doing that ahead of time. That's something you really want to stay on top of, because what's going to happen is your clients are going to still pay the copay to you, but you're not going to get reimbursed. So just be sure that you've got those dates on your calendar when you start to do that work. And now looking a little bit at consultation, there is kind of this triad of consultation where you have the consultee, which is you as the counselor, the consultant, which is the person that you're going to speak with, and you also have the client. And typically you are consulting about a client with your consultant. So as the counselor, you are the consultee reaching out to a consultant regarding your work with a client. Often there are reasons to consult, including maybe you are lacking in certain knowledge that could help you serve a client. Maybe there's a certain skill that you have not finely honed and you're consulting to build that more strongly. It could be that you are struggling with believing that you're capable of providing the most quality care to this client. And so you can get consultation to address that lack of confidence, to try and bolster you, to give you time to build that confidence and to check in so that you can verify that what you're doing is matching up with what your consultant might be recommending. Additionally, if there's a lack of objectivity, if you really want to serve this client, but you're finding that your bias might be getting in the way, this can be a really positive route to address that. I wanted to give you an example of some consultation work that I did because it's something that I very much enjoyed. And if you find that you really enjoy the process of consultation, you might want to consider gaining some education in consultation and serving as a consultant in your future work. In one of my past positions, I was the only queer identified individual who specialized in serving LGBTQ clients in a specific geographic area. So often I offered consultation for other practitioners who were working with LGBTIQ plus identified clients and were reaching some roadblocks, either because they'd never worked with these clients before, or because they were kind of working through some of their own bias in their mind and really had the desire to effectively, compassionately, and empathetically serve these clients. But then I also did some community consultation, and that's will be talked about on the next slide, but I want to go ahead and address it here. So I acted as a consultant for the Office of Juvenile Justice Services because they were seeking guidance on integrating LGBTIQ plus affirming practices within their detention facility. They had quite a large number of queer and trans youth of color that were incarcerated in that detention facility, and they were recognizing that these youth were experiencing higher rates of victimization and violence, and they wanted to explore how they could structurally shift the center to better provide safe and affirming care. And so I met with them every month, and we reviewed their policies. We reviewed things such as even something that feels so small as their kind of reward policy. So what they would do is if the youth were performing really well one week, they would give them incentives. They had this incentive program where they would give them something like they could earn a watch or a jacket or a number of items. But a lot of times these items were they were gendered in their coloring. So girls would get pink items, boys would get blue items. I don't understand the logic behind this to begin with, but um, we ended up talking about how they could either implement some more gender neutral items or they could allow the youth to select their own items, that they did not have to receive a blue item because they were read to be masculine, because they might identify as a girl or a woman. And so this was just kind of a small shift that started to show some of the kids that this place might be a safe place to come into their identities more fully, which is interesting because I think that these systems of incarceration often do so much violence, but some of these probation officers and the higher ups in the facility, you could tell they really cared for these youth that had a very unique and intersectional experience of marginalization. And so I felt hugely honored to be able to join them and start to shift some of those practices, as well as to educate some of the probation officers and higher ups about LGBTIQ identity and the needs unique to individuals who identify as such. So, consultation can also be done in a treatment team where different providers of one client's care come together to staff the case. So, for example, maybe you're working in a hospital setting. A treatment team might consist of you as the counselor, a social worker, the nurses that are charged for the client's care, the doctors and the surgeons, and then also the financial and transitions individuals. And you might come together once a week, staff the case so that you all are understanding what this client needs, and you're informed of the web of work being provided to the client by all of these different individuals so that your treatment goals can be aligned and facilitative of one another. So to address consultation within the family and the community, these are more kind of a casting a wider net of consultation, and they serve different purposes. So for family consultation, this can often be used if you are working with a client who is experiencing a pretty severely debilitating mental illness, or if you're working with a child who doesn't really have their own agency to provide their own care. You will often integrate family members. Now, if this client is an adult, you will still need client permission to disclose any information to family members. However, let's say that you've gotten that permission and you will bring family members in to really integrate them into the treatment as supporters. They can encourage this family member through their treatment, and they can also help to increase accountability for engaging in treatment. Additionally, you might share and explain what accurate expectations might look like for the family regarding this client's prognosis. So, for example, if you've been working with a client who's been hospitalized inpatient, and they have been really struggling to function in that day-to-day level, they might be getting released, and you would talk to the family about how the client has improved since they've gotten hospitalized, but also how their expectations might not need to be at that level that they were when the client went inpatient. For example, maybe this client is not expected to complete all of the chores that they were expected to do right when they came in. Maybe there's going to be a slow titration building up to their pre-hospitalization level of functioning. However, this needs to be done with more supports to avoid some backsliding. Additionally, consultation can be a space to allow family to process their fears, but also to access some tools for coping, for their own support, and then to release some of the self-blame. A lot of times family members will start to blame themselves, and there can be this very vicious cycle of spiraling downward and moving away from each other versus moving toward one another. So family consultation can be a place of psychoeducation where family members can be taught about some of the precipitators of their loved one's condition, and they can also be taught about their roles in uplifting this loved one once they are released from the hospital, if we're going with our example. Additionally, community consultation is going to be more systems focused, and this is going to be aimed to create a plan that's going to meet the needs of the community, but often there are multiple stakeholder groups within this community. So, for example, in the story that I shared about working with the Office of Juvenile Justice Services, or OJJS, the stakeholders in there were the higher up administrative level folks of OJJS, the probation officers, but also the youth that were in the detention center and their families. So I wanted to create a consultation plan that met the needs of everybody and still allowed the system to function in the way that was needed. And so now looking at referrals, there are going to be many reasons that you might refer a client or link a client to another provider while you are practicing. There could potentially be a shift in the level of care that's needed. For example, if a client you have been working with has been in the least restrictive level of care, coming to outpatient counseling once every week, and then they come to you and you see that their level of distress has significantly increased. Maybe they become a risk for safety because they are stating that they're experiencing an increase in suicidal ideation, maybe with a plan, access to means, as well as intent. You are going to need to go ahead and escalate and elevate that level of care. This might be sending them for an inpatient evaluation. This shift in level of care is going to be, hopefully, toward the least restrictive environment like we processed last week. But sometimes we do need to refer to a more protective and secure level of care to ensure their well-being. You might also engage in referrals when there's a change in the treatment protocol that's required for the client. So, for example, if a client is inpatient and they're doing really well and they're ready to do kind of a step down to an outpatient day program, this can happen when their risk for harming themselves or ending their lives subsides, and when they're feeling more balanced on appropriate meds. Additionally, when their motivation to participate in counseling and in treatment increases, this is a nice time for a step down treatment. However, like I just mentioned, you can do a step up to more intensive treatment if that's needed. You might also refer folks for supplementary services. So let's say that you've been working with a client for a while, and this was evidenced in the example in the book, but you've been working with a client for a while who has been presenting, let's say, with anxiety and depression. And for the first couple of months that you were working together, it seemed manageable, but in the last 2 or 3 months, you've seen their anxiety and depression spike, and you're recognizing that they're not able to complete daily tasks that they used to be able to complete. Maybe they're isolating and withdrawing from their community. Maybe you are seeing an increase in hopelessness, and a decrease in functioning. So you might want to go ahead and refer them to a psychiatrist for medications. If they're not wanting to go the Western route, you can refer to herbs or to other non-Western treatments. But make sure that you vet these services that you are referring to make sure that they are going to meet the client's needs and also honor the client. For example, if I'm working with a trans-identified client and I need to refer them for some psychotropic medications, I'm going to ensure that I am not going to send them to a psychiatrist who's going to disrespect their pronouns and have no awareness of trans-related health care and mental health. So it is our job in terms of advocacy to really vet our referral resources. Also, you might refer folks because you've had a change in your own circumstances. Maybe you are closing down a practice because you're choosing to go a different direction in your life. Maybe you're moving. But again, make sure that if you are referring a client to someone else, that you consult with that person beforehand, making sure that you're not referring clients to counselors who have fully booked schedules, making sure that the counselors you're referring your clients to are going to be a good fit, and also including your client in this process, letting them know that they are an active agent in choosing where they go after your journey ends. Additionally, you might have been working with a client for a very long time and you're finding that maybe you have done the level of work that you're going to do, that you have exhausted all of your options, you've done some really strong work together, but maybe they're needing a different type of treatment, maybe they're needing a different modality, or maybe they're needing just a different provider that can offer them something that is unique. Sometimes a different provider might be able to offer them challenge where it's really needed, and maybe you've gotten so comfortable in your therapeutic relationship that this has become harder for you to do. So you need to be self-reflective to recognize if you are not really serving this client anymore. Maybe you're not meeting their needs to the best or their needs to their expectations of change and growth. And then you might want to talk about referring out. So that is all I have for you today in terms of managed care, consultation, and referrals. We do not have a discussion board this week. However, next week's discussion board will allow you to process more about all of these topics, to ask any questions that you have remaining. So thank you so much for joining me today, and let me know if you have any questions or would like to process any of this information. Have a wonderful week.